Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 336 of our Pharmacotherapy MCQ series, which majors in medication therapy management and assessment of therapy. The first question reads, PNU, a 28-year-old man, has a BP of 140 systolic 100 diastolic. What is the primary problem? What subjective and objective data support the problem? And what additional subjective and objective data are not provided but usually are needed to define this particular problem?
The primary problem is hypertension. No subjective data are given. The objective data are the patient's age, sex, and BP of 140 systolic 100 diastolic. Each of these is important in designing a patient-specific therapy plan. Because hypertension often is an asymptomatic disease, subjective complaints such as headache, tiredness or anxiety, shortness of breath, chest pain, and visual changes usually are absent. If long-term complications such as rupturing of blood vessels in the eye, glomerular damage, or encephalopathy were present, subjective complaints might be blurring or loss of vision, fatigue, or confusion. Objective data would include a report by the physician on the findings of the chest examination, abnormal heart or lung sounds if secondary heart failure has developed, an ocular examination, e.g., presence of retinal hemorrhages, and laboratory data on renal function, such as blood urea nitrogen, creatinine, or creatinine clearance. To place these complications in better perspective, the rate of change should be stated. For example, the serum creatinine has increased from a level of 1 mg per deciliter 6 months ago to a value of 3 mg per deciliter today. Vague descriptions such as eye changes or kidney damage are of little value, because progressive damage to these end organs results from uncontrolled high BP, and disease progression needs to be monitored more precisely. The next question reads, DHL, a 36-year-old construction worker, tripped on a board at the construction site 2 days ago, sustaining an abrasion of his left shin. He presents to the emergency department with pain, redness, and swelling in the area of the injury. He is diagnosed as having cellulitis. What is the primary problem? What subjective and objective data support the problem? What additional subjective and objective data are not provided but usually are needed to define this particular problem? The primary problem is cellulitis of the left leg. Useful pieces of subjective information are DHL's description of how he injured his shin at a construction site and his current complaints of pain, redness, and swelling. The fact that he was at a construction site is indirect evidence of a possible dirty wound. Further information must be obtained about how he cleaned the wound after the injury and whether he has received a booster dose of tetanus toxoid within the past 10 years. Objectively, the wound is on the left shin. No other objective data are given. Additional data to obtain would be to document the intensity of the redness on a 1 to 4 plus scale, the size of the inflamed area as described by an area of demarcation, the circumference of his left shin compared with his right shin, the presence or absence of pus and any lymphatic involvement, his temperature, and a white blood cell count with differential. The next question reads, CSK, a 58-year-old woman, has had complaints of fatigue, ankle swelling, and shortness of breath, especially when lying down, for the past week. Physical examination shows distended neck veins, bilateral rales, an S3 gallop rhythm, and lower extremity edema. A chest radiograph shows an enlarged heart. She is diagnosed as having heart failure and is being treated with furosemide and digoxin. What is the primary problem or problems? What subjective and objective data support the problem or problems? What additional subjective and objective data are not provided but usually are needed to define this, or these particular problem or problems? The primary problem is systolic heart failure. Subjectively, CSK claims to be experiencing fatigue, ankle swelling, and shortness of breath, especially when lying down. She claims to have been taking furosemide and digoxin. An expanded description of these symptoms and her medication use would be helpful. The findings on physical examination and the enlarged heart on chest radiograph are objective data in support of the primary problem of heart failure. In addition, other objective findings that would help in her assessment would be the pulse rate, BP, serum creatinine, serum potassium concentration, digoxin blood level, a more thorough description of the rales on lung examination, extent of neck vein distension, and degree of leg edema. Pharmacy records could be screened to determine current dosages and refill patterns of the medications. In this case, a second primary problem may be present. Current recommendations for the management of heart failure include use of an angiotensin-converting enzyme inhibitor before or concurrent with digoxin therapy. Thus, a possible drug-related problem is the inappropriate choice of drug therapy, wrong drug. The patient or prescriber should be consulted to ascertain whether an ACE inhibitor has been used previously, any contraindications exist, or possible adverse effects were encountered. Regarding assessment, after the subjective and objective data have been gathered in support of specific listed problems, the practitioner should assess the acuity, severity, and importance of these problems. He or she should then identify all factors that could be causing or contributing to the problem. The assessment of the severity and acuity is important because the patient expects relief from the symptoms that are of particular concern at this time. During the initial encounter with a patient, it might be discovered that the medical problem is only a symptom complex and that a diagnosis is needed to more accurately identify the problem and further define its severity. The assessment is usually performed during or immediately after the data gathering, while the provider keeps in mind evidence-based practices. For example, if diabetes is assessed and pertinent subjective data, medication history, social history, diet, exercise, etc., and objective data exist, such as laboratory test results like hemoglobin A1C, low-density lipoprotein cholesterol, LDL cholesterol, BP, etc., then the assessment of diabetes may be to determine whether the patient is meeting the goals for the disease as defined by the ADA. If the patient is not at goal, then the explanation of the reasons why would be described in the assessment, and the plan would then be centered on helping that patient get to goal. Sometimes, the distinction between subjective information provided by the patient and assessments made by the practitioner are confused in the POMR. What the patient reveals belongs in the subjective data, and how the provider interprets it belongs in the assessment. For example, a patient stating that she is having difficulty affording her medications belongs in the subjective information. However, a patient appearing to have cost-related lack of adherence belongs in the assessment, because it is the provider's interpretation of what the patient has stated. Next we will discuss drug therapy assessment. A responsibility of the practitioner is to monitor the response of patients to prescribed therapeutic regimens. The purpose of drug therapy monitoring is to identify and solve drug-related problems and to ensure that all therapeutic objectives are being achieved. Unless proven otherwise, the medical diagnosis should be assumed to be correct. On occasion, the diagnosis may not be readily apparent, or a drug-induced problem may have been diagnosed incorrectly as being a disease entity. Healthcare practitioners share the responsibility to assess and monitor patient drug therapy. For the pharmacist, medication reconciliation and the drug therapy assessment may occur in many practice settings, including the community pharmacy while dispensing or refilling prescriptions or counseling patients, during MTMS encounters in the home or in the clinic, while assessing therapy for the hospitalized patient, or as part of routine monthly evaluations of patients residing in long-term care facilities. Many states have enacted legislation allowing pharmacists to develop collaborative drug therapy agreements with physicians for disease state management of common disorders such as asthma, diabetes, dyslipidemia, and hypertension. Additional services commonly provided by pharmacists through collaborative drug therapy agreements include anticoagulation monitoring, emergency contraception, and immunizations. These services often involve more detailed drug therapy evaluation and assessment and may occur within or outside the traditional pharmacy setting. Regardless, the patient's need, time constraints, working environment, and practitioner's skill level govern the extent of monitoring. Similarly, the exact steps used to monitor therapy and the order in which they are executed need to be adapted to a practitioner's personal style. Thus, the examples given in this chapter should be used by the reader as a guide rather than as a recipe in a cookbook. Next we will discuss the plan. The next step in the problem-oriented, i.e., SOAP, approach is to create a plan, which at the minimum should consist of a diagnostic plan and a medication action plan that includes patient education. The plan is the action that was justified in the assessment. The plan is clear and direct and does not require explanation. This should be explained in the assessment. For example, if a patient is experiencing constipation while taking an opioid pain reliever, the plan would be to recommend a stool softener or stimulant laxative such as docusase sodium. The plan should also include any follow-up that would be necessary as a result of the action taken. Next we will discuss the plan. The next step in the problem-oriented, i.e., SOAP, approach is to create a plan, which at the minimum should consist of a diagnostic plan and a medication action plan that includes patient education. The plan is the action that was justified in the assessment. The plan is clear and direct and does not require explanation. This should be explained in the assessment. For example, if a patient is experiencing constipation while taking an opioid pain reliever, the plan would be to recommend a stool softener or stimulant laxative such as docusase sodium. The plan should also include any follow-up that would be necessary as a result of the action taken.
So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 337.